Okay, this is a continuation of the auscultation portion of the heart. We had ended on the five components that we're going to describe when looking at the heart sounds. We ended on the rate and the rhythm, that we got to make sure that it does coincide with normal measures, and how if we find that it is a little different than that, or that we have an arrhythmic state, that we need to check also the radial pulse and make sure that there's no deficits in the rate in one as opposed to the rate in the other. So we're moving forward, and the second component that we want to measure is actually the carotid area, making sure that S1 coincides with that. So when you are auscultating, as such, you want to make sure that when you're hearing the apical pulse here, you want to make sure that you put your finger on the carotid here, and then you want to listen for that S1. When you hear that S1, you should feel a pulse on the carotid almost at the same time. And this is what I feel here. It does coincide with the carotid pulse. And then when listening to this S1, you want to make sure that there is no variation in its intensity, that there's any splitting of it, as this could also be caused by some type of abnormality. Now, we want to also listen to S1 and S2. Okay, the important thing to note about S1 and S2. S1 and S2 is in reference to the lub-dub of the heart, and of the closure of the semilunar valves, and of the tricuspid and the mitral valves as well. So when you're listening to these valves open and close like this, both the atrioventricular and the semilunar valves, when you listen to the lub-dub sound, you want to make sure that there are no murmurs or extra sounds there whenever you're listening. And you really have to listen closely, because sometimes, or most of the time, you cannot hear them very clearly, so you do have to listen for a good amount of time. So systole, the time to check systole is after S1 and before S2. That is a length of time during systole that you could hear for any abnormalities. S2, and then again to S1 again, would be the length of time that you would listen for any abnormalities during diastole. Now normally S2 is longer than S1. We all know that just from hearing the sounds. So you just want to make sure that you notice which one is which. Now one thing that we do need to note when you are auscultating is that when you have your patient laying down, you want to go ahead and ask him to go ahead and breathe deeply in and hold it, and then breathe out. Go ahead and breathe in again, and then out. When we hear this, one of the most important factors to note is that your S2 component actually splits whenever the patient inhales deeply. Now, we want people to know this just because this is normal, and we actually have a description of this splitting. We name one the aortic component, and the other the pulmonic component. This is all normal, and we'll get into later on what actually could describe an abnormal component of these extra sounds. So important to note that we do have 4 normal heart sounds, your S1 and S2, which we have described as the atrioventricular valves, also the semilunar valves, whether they're going from the ventricles to the lungs or the ventricles to the aorta. And then we are also describing S3 and S4, which are also normal sounds that are most of the time very, very hard to hear, and they occur during diastole. So after you hear that S2 beat, for example, you may have an S3 which comes right after that S2, or maybe a delayed extra sound coming at the end of S2, and that would be considered S4. So S3 and S4 are the extra sounds that you may hear that are not normally heard, but are also that are also normal if you do hear them. Now, let's go ahead and move into extra heart sounds. So we were talking about S3 and S4. S3 and S4 are normal unless they are increased. So by that I mean that you hear a galloping rhythm in, for example, S3, where you hear, and they normally have this word that they say that it almost sounds like this, where you have a Kentucky, Kentucky, Kentucky. And you can hear this very well with the bell of the stethoscope. Both S3 and S4 is better heard with the bell. And knowingly, S3 is better heard from the left lateral recumbent position, as well as S4. So we can go ahead and ask the patient to go ahead and lay down on his left side. That way we can hear the apex of the heart. So we're going to go ahead and position our stethoscope at the apex of the heart. And we're going to hear for any extra sounds after S2. Now, S3 happens a little before S4, so that's the way that you can differentiate. And S3, when it's increased, it sounds like I said Kentucky, Kentucky, Kentucky. But when S4 is increased, you actually hear Tennessee, Tennessee, Tennessee. So these are the type of things that you want to look for when you're hearing for this. Okay, so we're going to go ahead and stop here with this portion. We're going to go ahead and continue the last portion of this assessment on the next video.